Please.
I was going to too, and I was like, oh, I'm gonna get there.
Please, please help yourself, okay?
I'm gonna walk.
So,
I know. Cancel very.
What's your last name?
I know they are. Because otherwise it's going to change. Yeah. So I have to do it again to fix it. And you may get them after. I don't know where they come from, but every time I get it, they get bigger and bigger. Then they fall to the ground and right. It goes either way. Yeah.
Okay. Miss Pat would like to learn about the skinny shot. What is the skinny shot?
My friend just got Sabrina.
Oh, okay.
Yeah, that's fine. Sabrina is the perfect girl for you.
Hi, I'm Pat. It's the 1 week induction. Is this the semi-military? Yes. The 1 2 induction.
Yeah, no. Because he's been stuff too. Okay. Here? Here.
But you didn't have like no blisters or anything.
Perfect, Beatrice. I'm gonna go with no, you're totally fine. How long ago was that? Do you remember? 67. I'll go ahead and send her the message, and then she'll go ahead and contact you tomorrow.
Okay, yeah, please do. And also like some information if you have. Email is first month. And then were you?
What, you want to share it?
I wanted, yeah, to know if I could. I could do it today. I just want the information, but
The magic time.
well,
I'll have her double check, but I believe it is. I'll have her double check that for you, okay?
I did. I lost like 73 pounds from my surgery. But I gained a bunch of it back.
Okay, perfect. I'll go ahead and let her know to send that over to you as well. Is there anything else I can help you with? Perfect. I'll go ahead and give her all of these questions, and then she should be able to reach out to you tomorrow to clarify. You're welcome. Have a lovely day.
Hi.
hey, everybody.
It's like you're ready for us.
I'm just gonna go. I'll let her, just let me know.
Yeah.
Oh, heck yeah. Oh, yeah. Absolutely. Yeah, because you remember I had a different case. Yes.
Okay. I'm like, wait, I was like, okay, but that's what I was supposed to be doing. Okay, always
I'm slowly getting back into my life.
Perfect, you're all checked in. Have yourself some food, drink, and then have a seat.
Okay. Is there like presentation?
Yeah, there's going to be doing a presentation. We should be starting pretty soon, so if you want to help yourself to grab some refreshments, and then we'll go ahead and give you all the information, and if you want to know anything more specific, they'll just coordinator available at the end.
Thank you.
Of course.
I don't know when, but I saw something flash. Okay, well now for the actual
Yeah, it'll be like 21.
Yeah.
Had mine for like 5 years.
Yeah, just want to keep it.
Ah, you like that. You want to talk? Sure. I don't care.
She's only 18.
Hey, Julie. Okay, we're good. All right, thank you guys for coming. I'm Dr. Mata. This is Dr. Benjamin, my partner in crime. And we're here to talk about rapid recovery breast augmentation. So what does that mean?
So the whole point of rapid recovery breast augmentation has to do with how we numb the pocket, to create, do the surgery and the recovery process afterwards. And a lot of it is combining light anesthesia with what we have something called tumescence. It's a solution of saline combined with light can really numb everything so that you're so much faster. In a couple of days you feel great, and that's the whole point.
So, to add to what Dr. Benjamin's saying, usually when you have surgery for this, you get a breathing tube, they knock you out, they cut you, we put an implant in, we close you, and then we put numbing medicine at the very end of the surgery. So you can imagine, it's kind of like, hey, let me break your bone, let me put it in a cast, and you're okay. The way we do it is like, hey, I'm going to make sure your arm is totally numb before we do anything at all. So because we do it that way, when you wake up, you're like, hey, it doesn't hurt even though it's broken. Which is an interesting philosophy because the way medicine goes is injure first, then numb, as opposed to we're numbing before we ever touch anything. So by default, when you wake up, you don't pressure and not pain. That's what allows the rapid recovery aspect. So, surgical technique.
So ultimately it has to do with, like we mentioned, is numbing the pocket before doing any surgical dissection. The source of the pain, it's numbing the entire breast, numbing the incision before any cuts are made, and just helps you during surgery, and then helps you even after surgery. Most patients, like I said, within 48 hours, pretty good. That doesn't necessarily mean you can work out right. You gotta wait till you heal. But that's the rapid recovery technique.
And the thing that sometimes we get into the weeds about is we don't just numb the incision, we numb the entire breast. The whole entire aspect of it, so it's not just where we're cutting or we're working, we numb everything. So that way when you wake up, you truly are feeling like chest pressure, like someone's kind of sitting on you a little bit, like maybe, a 2-year-old. That's what it kind of feels like from that standpoint, just pressure, not true excruciating pain. That's part of the difference in terms of surgical technique.
Yeah, and it's a very much the no-touch technique is what both of us sort of use, and this is, at least in the plastic surgery world, this is like, it's been well published. And why no touch? Why is it so important not to touch the implant when we're doing the surgery? It's because it has to do with what's called capsular contracture, which is the most common complication or issue that can arise after a breast augmentation. So that implant goes literally from the sterile pack. Even though the surgical field is sterile, even though our gloves are sterile, we change our gloves. We use what's called a Keller funnel, which kind of looks like a baker's funnel if you've ever seen it. So the implant literally goes from that box to the funnel without us touching it, and then it goes inside the patient without anyone manipulating the implant. And you want to keep, because our skin flora has bacteria on it. Even if you sterilize it, you can always have a handful of bacteria, so you really want to minimize that implant touching anything. That's all part of the technique. So that sets you up for success years and years down the road without having any issues.
The only thing that I would add to this is, you know, you can see the color funnel is more of like instant loop. The minute we kind of squeeze it, it slides right in. So if you've seen videos or pictures of people using their fingers to try to squeeze it in, that's could theoretically damage the implant back and forth, back and forth, back and forth. And the reason we use this kind of brown thing is because it's got iodine on it. And so it protects the skin, the funnel protects the skin. And so it never really touches the skin, so no risk of contamination, right? But the other thing too is this allows us to make a very, very small incision. So most people would use 5, 6, maybe 7 centimeters, so about this much. With what we do it and how we do it, we make the incision about half the size, so about 3.5 centimeters, which is the size of the instrument that we need to actually do the surgery. So it allows us to have a smaller scar. If you have a smaller scar, you have less chance of infection, less chance of issues, all going in the right direction, not the bad direction.
So dual plane technique, you're going to hear this probably mentioned by a lot of plastic surgeons if you've sort of been looking at getting a breast augmentation. All that means is, you know, and it varies in patient, I should say, but the majority of the time we try to place the implant underneath the muscle that you have, your pectoralis muscle. Now, it's sort of a misnomer. The reason it's called a dual plane is because that whole implant never really fits underneath the whole muscle. It's usually the top 1/3 to 2/3 of the implant that's sitting underneath the muscle to help give you a nice, gentle contour. And then, you know, we split the muscle, leaving like just a little bit of muscle at the bottom. For some patients, we actually do place the implant above the muscle because it can give you a little bit of a pseudo lift, is what we say. If you have a little bit of droopy breast tissue, sometimes you can compensate for that droop by placing it above the muscle, which is actually, I think, the majority of how they do it in the rest of the world. But in the U.S., for the most part, we place it underneath the muscle. But there's misnomers. You know, there's pros and cons, and it really has to do with your own anatomy. And that's part of what we go through when we see a consult, when we see a patient. You know, all of this is sort of tailored to you and what your expectations are, what you want to see as your result.
Yeah. I would just say no two breasts are created equal, right? You can look in the mirror, they're not exactly the same. They're sisters, sometimes cousins. But the goal is for when we're done, for them to look very, very similar, right? Close relatives, sometimes, you know, everybody wants identical twins, but there's no such thing, right? But like Dr. Benjamin was saying, you know, if you guys have done any kind of research, you know, like, oh, I need to go under the muscle. Why? Does everybody say, oh my gosh, we have to go under the muscle? Nobody knows, right? It's just like, well, that's the way my friend had it, or that's what I heard is the best. The reason that came about was in 1982, silicone implants were taken off the market, right? Oh my gosh, silicone implants were the worst thing ever. So they were taken off the market for 14 years. And at that time, you could only get saline implants. Saline implants have a lot of ripples, a lot of folding. And if you're very skinny, you can see all those things. Let's just put them under the muscle to help camouflage. So this is your breast tissue. This little kind of brown line is your muscle. So it adds a little barrier, so it camouflages it, so you don't see as much rippling. But because for a 14-year period, all these surgeons trained a certain way, that's all they know. The rest of the world, since probably, because you know silicone implants were first started in Houston, Texas in 1962, 64, the rest of the world adopted this. And they've been putting their implants above the muscle for as long as anybody really knows. Because if you think about it, where's the breast tissue? Under the muscle, above the muscle? It's above the muscle. So why would you put something round under this muscle? To camouflage, to basically stop the contour issues. That's why you would put an implant under the muscle. Nowadays, that's what everybody knows. And again, there's nothing above or below the muscle. It's just what makes most sense for you and your twins, your cousins, your distant relatives. It's just what's going to look best on you. And just because somebody has it a certain way, and you're like, oh my God, that's exactly what I want. Unless you're identical twins, it might not look that way, regardless of how I do it or Dr. Benjamin does.
And then in terms of, you know, what you want to see, at least with regards to the Sientra implants, you want a high strength cohesive gel. So it has to do with rippling. You know, one of the ways we camouflage, of course, the ribbons by placing underneath the muscle, but the other way is really has to do with how cohesive that implant is. If you pick it up and you squeeze it, you want it as close to as natural breast tissue as possible. The Sientra implants in particular have a 20-year warranty. Very common question I get from patients is, oh, does that mean at 20 years I have to have them swapped out? You don't. And there's some patients who have implants that go far beyond. As long as you're having normal follow-ups and you don't have issues and you look great, there's no reason to swap them. Some patients do decide to swap before the 20 year. So it just kind of depends. That's a warranty on the implant itself. And there's so many different types of implants, like over 375 in terms of different projections from your chest, different widths. And a lot of this is what we go through during the consultation when we take your measurements, really tailor the breast implant to you. You know, at least for me personally, I never choose the breast implant for my patients. I try to guide you, and there is a guide to get you the results that you want. You kind of decide on the size that you want yourself.
So imagine, how would you pick 1 out of 375?
Yeah, it's easy.
Because I saw it on YouTube or Instagram or TikTok, like, oh, I like a 375. Doesn't matter,
Sweet, you did a 375. I want those.
right?
Yeah.
So it's like shopping for clothes, right? Whatever you go to the store, you're gonna gravitate to whatever style you like. Implants are no different. It's our job as surgeons to sit here and to listen to what you guys are saying in terms of, well, like, I like this color. I like a short dress or a wide dress or whatever the circumstances are. And it's our job to weed that 375 down to
You're perfect.
maybe 3 or 4 pairs. And then from that, decide what it is. Because if I said, okay, here's 375, the 2 that you like. You know, one might be totally different on one side compared to the other, depending on your starting point. You know, something that, you know, with having such a wide range, it helps us get you as close to twins as possible. Even though, you know, I say we deal with imperfect people, meaning the foundation that we're working with, and we're imperfect surgeons, because there's no such thing as a perfect surgeon, right? So it's our job to take all of these little tweaks and nuances, and based on what you're telling us and showing us, get you that kind of result and that kind of look in a safe fashion. The one thing that I think is interesting about Sientra when we talk about warranties, so the 20-year warranty, what that actually means is, like, let's say it pops at year 19, right? You're like, oh my gosh, here's luxury. Great, the company will help you. After 20 years, the implants have lifetime warranty against rupture. So let's say it was a 10-year warranty, the rupture's at year 12. All companies will give you a new implant. They won't help you pay for surgery to help fix them. So before the warranty expires, if it ruptures, the company helps you with a little bit of money to help kind of fix it. The way I describe it is, you have a car, your motor goes out after 3 years, right? 36 months. It goes out in month 38, you're like, damn, I'm gonna need a new motor. You have to pay for it. The companies basically give you a motor, you just have to pay somebody to put it in. That's at least how I see the warranty, where it kind of makes sense, where they're guaranteed forever. So if you bought a car and they guarantee the motor forever, you're like, that's a pretty good car, right? So that's kind of how the warranty stuff works.
Yeah, and there's so many, that's sort of what we were touching base on in terms of profiles. It really has to do with the projection from your chest, and has to do with expectations. So, you know, the wider, one of the measurements we often do in our consult is we're gonna have you raise your arms above your head and kind of measure the chest width. What we're trying to measure is that pectoralis muscle to get an idea of what your base width or what the width is of your chest, and that kind of suggests what type of implant we're looking for, and then it has to do with how much projection you're seeking. So the nice thing about Sientra is they give us so many different shapes and sizes, and it just gives us more tools in our tool belt to be able to tailor, you know, the implant to you.
So by show of hands, how many people know the difference between high and moderate profile? So what does it mean?
I have high profile right now, it just kind of sits up, so I hit them, it sits up higher on my chest.
Okay, so if you were to look at these and I were to tell you they were pretty much all the same width, meaning how much this is apart, that's what high and moderate, the way I try to explain it. So imagine you're building a house, it's a 1-story house. You have no more real estate because you're going into your neighbor's, right? There's only so much space, and now you're like, but I want a bigger house. So where's the only direction you can go? Up. Up means this. So high profile, assuming there's no more real estate to work with across, goes this way. If you pick a moderate, it's actually going to be still the same width, but just a little bit flatter. But then when you're talking about, well, I want a 350 high or a 350 moderate, the moderate's actually going to be wider than a 350 high. So how much they project will change a little bit. And that's where, again, a lot of people will say, high means this. High does not mean this. High means this.
It's off your chest.
How much it's sticking out this way. It's that 2-story house versus a 1-story house. And usually, at least in my experience of doing this for however long I've been doing it, people want cleavage, people want some side boob, not too much, and then some fullness on top. And depending on how high you want it, based on your starting point, will determine whether you get a higher or moderate. A lot of times I see a lot of patients like, hey, I want them really high here. No, they're like, I want a high profile. And I'm like, maybe you do, maybe you don't. Because if we pick up high based on, I want a 350 high, and I'm like, well, actually a 350 moderate will give you more of this than the high because it's going to live wider on your chest. So those are some of the little nuances that I think that misinformation's out on the web, or like, oh, high profile means this, and I'm like, it really doesn't. If you lay the implant down and just look at it, you're like, oh my gosh, you're right. It gives you a different shot.
Most common incision types, at least that we use, there's the periareolar, we're going through the nipple areola, and some people like that because it's, you know, hidden around the color of the areola itself versus the skin. Most common I personally like to use is the one underneath the breast. Try to keep it as small as possible because when you look at someone, it's very hard to see that. But it really is tailored to your breast. Some patients have, you know, not to complicate things, something called tuberous breast, where breast tissue itself is very coney, and so going through a periareolar allows us to release some of that breast tissue. Because it's all about redistributing the breast tissue on top of that implant. So, you know, these are probably the two most common. There are other incision types. I personally don't recommend or do. I don't know if you do.
So there's actually 4 incisions: armpit, nipple, breastfold, belly button.
Belly button, yeah.
Okay. It just kind of depends. When I practiced in Texas, everybody wanted armpit, so I did a lot of armpit incisions, and you can put a silicone implant through the armpit. Typically when I do that, I use what's called an endoscope. So it's basically like a camera. Like I'm looking at the TV as I'm operating. I'm not actually looking at you. I make the incision and I'm literally looking at the TV as I'm doing the surgery. That's endoscopic. The next incision is around the nipple, like Dr. Benjamin said. You know, the reason that one does kind of well, when I was in Miami, Florida, everybody wanted a nipple incision. Nobody wanted anything else. So for a period of years, that's all I did. And the reason this works well is if you look at the ceiling and you look at the trim, there's a line there. But because there's a difference in color or texture, it hides really well. So when you make an incision in the nipple, if there's a color change, it's almost imperceptible, where you look at it and you'll be like, where's the scar? It's physically there, but it hides because of the color change. Our eyes cannot see that difference. You see corners, but if I put a line in that corner, you won't physically see it. And then of course, the one that's probably used 70-80% of the time in the United States is under the breastfold. When I did some training in Colombia, it didn't matter what it was, everybody wanted around the nipple. So it just depends. The one that I typically don't do is the belly button. I've done a couple of them. And because it's literally just sticking a tube and shoving a saline implant in there, you're not really cutting muscle, you're just kind of blowing up a balloon and seeing how good it stretches and then moving the muscle around. The thing about these 2 incisions is that anytime you have had a surgery, these are the 2 that you're going to use to fix something. One way or another. You either use this or this if you're not doing a lift. With the armpit, you can't fix anything. 1 out of 8 or 9 women has breast cancer. When you go through this, you're ruining the ability to check for breast cancer. When you go through the belly button, you cannot fix anything through the belly button. So you're going to get a scar on your nipple, on your breastfold, one way or another. So these 2 are usually the ones we do in the office, and on a case-by-case basis. If you want to do the armpit, I would take you to the hospital and do it. I don't know if Dr. Benjamin can say that.
I really don't recommend it. So in terms of recovery, it's very fast. I mean, it's part of our rapid recovery technique. It's really, in terms of discomfort, you're not going to be feeling a whole lot of pain, and you know, it's mostly going to be a chest pressure that you're going to feel. Because you know, I always tell my patients, make sure you're taking deep breaths in. You know, they see me after surgery because the lungs need to expand, but you're going to be experiencing just the pressure of the implant, not really the pain. And about 48 hours, most patients adapt to that. And so it really allows for patients to go home the same day. Both of us make it a policy to see our patients the next day, and then we each have our own schedules in terms of like seeing patients. Typically, it's post-op day 1, post-op day 7, make sure everything is great, and we continue thereafter. But it's typically a pretty quick turnaround. The only thing I usually tell my patients, I'm glad you feel great after a couple of days. Just take it easy. Take it easy. That's usually the issue.
I think part of the goal when we do it the way we do it in terms of the rapid recovery aspect is if you have surgery in the morning, depending on how you take the anesthesia, because again, all the medicine's through your vein, no breathing tube. The way I describe it is if you drink alcohol, right? If you've had 3 glasses of wine, can you be totally functional, or would you be passed out until the next couple of days? So everyone kind of responds to the anesthesia differently, but if you had 3 glasses and you're like, I'm fine in a couple hours, then I would say if you had surgery in the morning, you could go out to dinner that night. You don't feel like, oh my gosh, like the world's coming to an end and it's so terribly bad. And we'll show you a little video of one of our. Oh, there's a light on it.
It's just muted.
Doesn't it, does audio?
No, it's not muted.
Well, never, it's not going. So here's some of my patients. Different starting points, different sizes. Can you guys, which one is bigger between these two? If you were to say, between tattoo and this one?
Between which two?
Between these two, this one and this one, which one's bigger? Implant wise.
I mean, they kind of look the same, but I think it's right. I think they're more technical profiles, probably, right?
No, the profile's the same for both. But this one's bigger by about like 30%.
It's hard to tell sometimes. That's
This is a 345, this is about a 475. And again, just the dynamics. She's very petite. She had big implants for her, but if you said a 375, that wouldn't be like, oh my gosh, it's like a crazy high number. Versus you hear 400s or almost 500s, so like, oh my god, that's huge. But the dynamics in her frame, I think they're pretty balanced versus these look really big because her frame is really small. So that's not why one size, one shape fits everybody. Because you guys might, if I put 500 in every single person in here, they would all look drastically different. It's part of the dynamics.
Yeah, and here's some of my before and afters as well, and it really has to do with, trying to pick an implant that fits your frame, fits your shape, and a lot of it has to do with height and weight and, what you're looking for, a more natural appearance, a more augmented appearance, and then we kind of go through the spiel in terms of like, how much cleavage you're looking for. Some women want their breasts to touch, and sometimes the anatomy allows for that. Sometimes they want their breasts to touch, but unfortunately, we'll try to get her as close as possible to that. It has to do with, how your ribs are. And we go through that, and there's a vector machine in there that we scan your chest and sort of talk about your ribs and the foundation where the implants sit at. And that's kind of what I'm trying to get at. It really just depends on your own anatomy. We can have 2 patients with the same exact implants, and they're going to get a completely different result.
The one thing that he was mentioning with Vector, it's a 3D camera. So when you come in for a consultation, we'll actually take a picture of you, and then we'll be able to show you a before and after in 3D. So you actually get to try it before you buy it. The old way to do it was to put a bra on and shove the implants, or take a rice bag in there that weighs so much and put it in there and be like, oh my god, how does this look?
We have some of those in there too.
If we were in the 1980s, I would say yes, that's literally the only way. But I mean, with AI, like pretty much everywhere, with Facetune, all this, I mean, we've had, the 3D camera for probably 12 years. It's been around, but not a lot of people have it because it's a little pricey. But if it allows you to see your results before you're having surgery, as opposed to, well, I think this one's going to look really good. And when you look at it in close, how are you going to tell the difference between a 325 and a 345? And be like, oh my gosh, I really want the 345. I don't know if I can get that little bit of extra. That's where the 3D camera really helps for you to physically visualize yourself. Not a bunch of different before and after pictures, but physically you before you have surgery, so then you can really feel comfortable about the decision you're making. So, what questions do you guys have?
So on any of those photos that you showed us, did anyone have any lifts
anything else, guys, that you guys can do about it? Yes.
So you say you numb it, how long after the surgery is the numbing gonna go away?
6 to 24 hours. I find that some patients may last a little bit longer. And by the same, I guess, idea or concept is if, you know, if you're on social media and you've seen stuff, people say, hey, I'm gonna use Expro, long-acting anesthesia, right? And they sit here and then they will numb your ribs. So they literally stick a needle and try to numb it that way. They still do the surgery the regular way, but they put that numbing in there. Yeah, it does last 2 to 3 days, so 48 to 72 hours. There is an additional cost. But the way you do it is put your tube in, do the surgery, numb you at the end. You're bypassing everything that we said. It's better to numb you at the beginning. The catch with that medicine is the way we do it when we numb you everywhere and you put that medicine, it doesn't work. It causes all those little, basically numbing pockets to basically pop. So you get numbing for 12 hours if we were to do it that way, which is kind of a wasted cost because what we do is 6 to 24 hours anyways.
And it also buys you enough time to where, you know, everyone's prescribed oral pain medicine so that you can get it into your system, and that's part of why you feel great, because you've had this numbing medication carry you through to get the oral pain medicine into your system to reach therapeutic levels so that you're comfortable for the next couple of days. You don't have to wait. And then the pain sets in, and now you're taking oral pain meds, and now you're in even more pain. You're waiting for that to actually kick in.
Does that, affect the swelling that you might have?
No.
It doesn't, so you'll have the same amount of time as swelling as you're gonna have anyways, okay.
Yeah, it doesn't make, the amount of numbing that we put in there is not so much like, oh my gosh, her breasts are like this big and they're gonna end up like this. No, it doesn't do any of that.
It doesn't do that, and it doesn't stop the swelling, like, you'll
No.
get the same amount of swelling as you would before, okay.
But I would say yes and no to that question because the catch when you do surgery is if you are proactive. If you see that if you keep driving, you're gonna get in an accident, what are you gonna do? You're gonna avoid that accident, right? You're not just gonna keep driving and rear-end somebody. So when we numb everything, we actually get to see stuff that sometimes when you're just going through it, you're not seeing. So because you're proactive about it, you have less bleeding. The less bleeding you have, the less trauma we're causing to your body, so thus the recovery will be faster. Does that make sense?
No, it does make sense. And then how long would the recovery, like say, because I work in a hospital, I work in a hospital, I do patient care, frontline worker. So how long would I be out of work?
1 to 3 days.
1 to 3 days?
I have a question on these. Are these above or below the muscle?
Days.
Oh, on mine? Combination, actually, I want to say the majority of these are above the muscle. There's one of these that's below. Or no, the majority are below the muscle, one of these above.
Because this first one in the bottom left, it looks like she kind of got like a lift with it.
Yeah, so it's a dual plane, yeah. So when I was talking about dual plane, how some of the implant can go underneath the muscle, so depending on where you cut that muscle to put that implant in, you can compensate for some of the breast tissue. And that's the art, the magic to this, to try to compensate. Because a lot of women, you know, see us for breast augmentation, you know, most of them are candidates, some have that little bit of breast droop, but they still want that augmented look. So there's things that we can do surgically in terms of technique to try to give you a really good result without buying yourself the lift. You may need a lift down the line. And so that's why, you know, we try, at least for me personally, I try to place things underneath the muscle as much as I can because it gives a little bit more of a natural result, a little bit more of a natural contour. It also protects the implant, decreases capsular contracture. There's a lot of benefits that I see to it, but not everyone is a candidate. So again, we kind of tailor it to you.
How different is all of this as far as like corrective surgery for like botched surgeries?
You know, I do a lot of revision breast surgery. Probably half of all the breast cases I do are revisions. I think last week I did somebody who had 8 previous breast surgeries. Hey, I've had an implants and they're 10 years old, I want to change them. When you're talking to, I still follow exactly, and I know Dr. Benjamin does as well, we still go through the same process. We still numb the entire breast before we do anything. But obviously there's going to be more cutting. And the hardest part about revision breast surgery is like, you're buying a fixer-upper, you don't inspect it, you walk in and you're like, oh, this will be easy, and next thing you know, you're like, oh, there's termites, there's bad electricity, the roof. That's kind of how it is when you look at the outside, you're like, oh, it looks fine, it's okay. And then when you get in there and you're like, oh my gosh, this muscle's cut here, this one's cut here, this one's split in half, this has all kinds of mess, and that's why when you do revision breast surgery, you really got to be comfortable with, you got to be a general contractor. You got to be able to come in and fix whatever you see in there.
Now, can you change, like if they go under the muscle, can you go above
Yes.
the muscle? You can either
Correct.
way, whichever one fits and suits better for the person.
Correct. And sometimes, even though we might talk about a certain thing a certain way, I get in there and I'm like, you want it to go under the muscle, and your muscle's like this much. So there's no way I'm gonna get any kind of muscle to cover your breast implant at that point. So sometimes, Dr. Benjamin, we have to make an audible.
Is
we have
healing
to-
time different?
I'm sorry?
Is
No.
healing time different if you're doing, start
No.
or just getting a revision?
No.
done?
When it comes to revisions, it's just about what we end up having to do. The recovery is still 6 weeks. The only thing I would add when you're talking about redo breast surgery, if we use mesh, I tell you it might be more like 3 months, because I really want that reinforcement of whatever I'm putting in there, that internal bra, to really kind of like Jello. It's almost set, but it's not quite there. You gotta let it sit a little bit longer so that it does better. Usually I find people that 8 breast surgeries, they've had all kinds of stuff in and out. And I'm like, God, you've had mesh, you've had this. And I'm like, why didn't it work? It's 'cause sometimes people overdo it, or the doctors don't kind of slow it down a little bit for the patients to say, hey, it's fine, go do X, Y, Z, and it really hasn't set or been fixed yet. So,
Yeah, it just kind of has to do it. And then part of it all starts with the revision work, at least for me. It's all preoperative. So we go through maneuvers, we kind of examine you, see what the issue is. And a lot of times we can figure it out, but sometimes, like Dr. Mata said, we're in the operating room and you just got to figure out what the audible is, but you've had a discussion with the patient, you know what the expectations are and what you were trying to achieve. So setting up the patient for successful.
I think the one thing to kind of add to when you're talking about revision surgery is usually I don't like surprises. I like to know, like, hey, if you want a 500, we're going to do a 500. If it's a 200, we'll do a 200, or whatever size it is. I think one time in 17 years, I told the patient we were going to get this size, and I literally put it in, and I was like, I physically can't close it. So we had to downsize. But usually, that's few and far between. Like I said, one time out of God knows how many thousands that I physically couldn't get the implant in that we thought we were going to get in there. So.
I couldn't hear the part where you said something about the tube. You don't use a tube in the.
No, it's not general anesthesia.
Oh, it's not.
No. That's the whole
Yeah.
crux of everything that we're doing. All the medicine actually goes through your vein. It's called total intravenous anesthesia.
So is it like Twilight?
Yes, propofol.
Yes.
Phenol, Versed,
So you're breathing on your own, but there's no tube that goes down, which is in many ways
I couldn't hear that
advantageous.
part.
Yeah. Your blood circulation is normal, so that when the tube goes down, part of the issue with the tube that goes down, besides the nausea from the gas, is your blood circulation actually slows down drastically. So your blood clot rate can go up. There's other complications that can happen from anesthesia. It's a much deeper anesthesia that is not necessary, I'd say, for the majority of elective plastic surgery.
Even if it's a revision?
Yeah,
Yeah.
even if it's a revision. Yeah, I've been doing it this way since
You just gotta know how to know.
2009, 2010, somewhere around there. And if you look at plastic surgery stuff, a lot of surgeons, like if you look at other countries, they literally just put a spinal in people. So kind of like when you're having a baby, and they do it that way for the body stuff. That's a little much for me because you're totally awake versus some of the medicine just helps you relax in your brain where you're like, I don't really want to know what's going on kind of stuff, but you're still breathing on your own. And the thing with general is that you get paralyzed. Like you physically can't move. And that's where the patients have issues like, oh my gosh, I'm awake, but nobody knows because, the type of anesthesia versus this way, it literally tells your brain to kind of calm down. It's like we give you enough alcohol to where you're like, I'm really good, and you fall asleep, and I'm like, hey, wake up, and you're like, hey, I'm okay. You literally close your eyes, you open your eyes, and surgery's over.
Yeah.
That's the perception of our patients when we do this kind of anesthesia. It's not that we can't do general. If you want general, we'll take you to the hospital. It's no problem, no big deal. But we find that people recover much faster, much easier this way. Because when you're under general, you're paralyzed. We just cut close, you don't worry about stuff. Versus this way, we're making sure you're not before we start.
How long is the surgery usually?
It's pretty quick. I take my time. I usually do up to like 45 minutes to an hour for breast augmentation.
Oh, that's taking your time.
That's like
That's pretty, so like an hour.
an hour. It's
Hour or less. Yeah.
parents had to use a special camera to kind
Yeah.
of show you. Is there, like, do you still use that ancient bra you guys are talking about to feel like how heavy it's gonna be?
Yeah, we have
Yeah.
sizers that we can
Yeah.
actually give you so you understand actually how much
You
it
could kind of
weighs. So
feel
you're like, hey, what does 600 feel
Because you're gonna
like?
hold it. Yeah. So you look at
It's
the,
different holding it than
Exactly.
like
Correct.
on
Yeah,
your chest.
correct, yeah.
you're gonna feel, you're like, oh, that's what a 5. You're like, oh, I like the 500, and you actually hold it. You're like, wait a second, it's 2 of these. And like, how does this change my center of gravity?
Yes.
And, yeah,
So, and BMI requirement.
I don't have a BMI requirement. It's very tailored to what your comorbidities are. You know, I have patients that have BMIs of 20, but they have too many medical problems where like it's just not safe for you. And I have patients that have BMI of 36, 37, 38, and they're very healthy, you know, otherwise. So it's really, I don't have strict cutoffs. It's really tailored to the patient. As long as the safety profile meets it, I'm going to do the surgery. Yeah.
Question?
If you had over the muscle and went to under the muscle, does that act as a lift somewhat?
No.
No. Okay.
Part of the dynamics that when you're talking about revision surgery is you have a big empty hole. Now you take this muscle and you still have a big empty hole. So part of this is how do you fix that big empty hole so that when you put it under the muscle, the implant doesn't just go pop and go right back to where it was. That's the revision aspect, the fun part about what we do, because no case is exactly the same. No two sides are exactly the same. No two muscles are even exactly the same. So this is where the art part of what you're doing comes into play. Because sometimes I see patients like, oh, I was under the muscle, they did a revision, they told me this, and I go in and I'm like, no, it's above the muscle. So, just little maneuvers, little tricks. What else?
Does it matter if you're going smaller?
In terms of?
Going above or under?
No, I don't think it really matters, but I think anytime you downsize, it's like, hey, I'm gonna lose weight, right? What happens to my clothes? It becomes a little bit. What happens to that skin if you downsize? It becomes a little bit more saggy. So that's when, depending on how small you go or the circumstances, you may need a lift. The skin. So I'm losing weight. Well, I want this to be form-fitting. Well, I need to cut some skin.
And that goes for both the outside of the skin as well as the inside. Because remember, the implants, they take up a space. So if you had a larger implant and now you want to go significantly smaller, that space has already been created. So we have to also sort of tailor that, what's called a capsule. Every breast implant gets a capsule, but tailor that capsule to your new implant. So sometimes it requires capsule work in terms of revision.
But sometimes if we're lucky, we can literally, depending on how lucky or how good we are, we can sit here and take out an implant, downsize, and not do a lift.
Yeah.
Some of my staff members in the past have twisted my arm to no lifts, and somehow or other we've managed to get lucky that way. But again, it's always on a case-by-case basis.
What does a lift involve? None of these photos show that.
No, a lift is basically taking somebody who's droopy and basically putting in an implant and tightening the skin so that it looks like this. Most of the goal of lifts is this. You would say like she might have needed a lift. If she didn't get an implant, you'd have a scar, and a scar, where you tailor. So it's like you have a dress and you're like, okay, great, I want you to take it in. Well, do you want me to take it in just here, 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 here? The more you tailor, the more skin you remove, the more form-fitting it is. So the more likely for you to end up with a nice, tight breast in terms of, wow, that looks turkey. We might have to remove more skin, which means a little bit more scar.
I'm sorry.
But usually I tell people, you always trade shape for scar. The more shape you want, the more scar you need to usually get.
Where would the scars be?
Well, they would go around the nipple,
Oh.
down, and sometimes around here. Everyone's like, well, I don't want scars here. I'm like, great, would you want a scar here for us to lift it up here? No. So part of this is we hide the scars in a place where you can still wear clothing, a swimsuit, and it hides very well. I would say most patients, 6 months to a year, the scar ends up looking like a stretch mark long term. But it does take time. Anything else, guys?
Is it like stitches or is it like nothing that needs to be removed, right? Because I have like this phobia of stitches with like the black stitches.
Oh,
No?
yeah. I mean, the sutures I use are all dissolvable.
Okay.
Sometimes we leave the little ends out and we just kind of trim the outside of the sutures. Everything's dissolvable, it falls off on its own. I like to leave the sutures on the outside, trim on the outside, because I don't like leaving knots. Sometimes things can spit as the suture's dissolving. But yeah, there's no permanent, there's no nylons, if you're talking about a black suture, I don't use that.
Yeah. Anything else? Very good questions, guys. Please help yourselves, and we'll be around for a little while.
We'll be around.
Okay? Thank you.
Feel free to grab us.
If you guys are interested in breast procedure or any other procedure types, you guys can fill this out and either give it to any of us or just stick it back on the table.
Please grab food and drink, legs for my
I'm pretending to think about